Aloha. Thank you for coming today for the first of 4 webinars about the new MedQuest Palliative Care Benefit. My name's Jeanette Kojane, and I'm the Executive Director of Kukuamau. Thanks to a grant from Huipohala, Kukuamau has organized this series. And I do want to do a shout out to our team in the background who is making everything happen. So the first 3 webinars are for professionals, and the final one is for the public. We really appreciate your help in spreading the word about the new benefit and also the webinar series. So today we have 3 speakers, Judy Moore-Peterson, Dr. Daniel Fishberg, and Tori Fields. After the presentations, there'll be a live Q&A session. So please put any questions you have in the Q&A as we go along. And before we start with the presentations, I do want to take a minute and thank everyone who has worked on making this benefit a reality over the years and helping us to be the first state in the country to be able to offer this to our people. So thank you again for coming, and we'll start the presentations.
Hi, I'm Judy Moore-Peterson, MedQuest Administrator in Hawaii. Aloha, and thank you so much for attending this webinar series on the new Medicaid benefit for community palliative care. You know, we all want high quality care for ourselves and our family, especially when we have a serious illness. Unfortunately, we have a fragmented, confusing healthcare system. And the more complex your health and healthcare needs are, the more challenging it is. Navigating the healthcare system to get comprehensive, coordinated care can be extremely difficult. And community palliative care helps fill this gap and is the type of care we need for individuals with serious illness. It provides extra support from a multidisciplinary team that bridges all care settings, geographies, and cultures. It truly represents a whole person approach to care that we all value. For this reason, we at MedQuest recognized the need to make community palliative care a regular part of the Medicaid benefit. With the approval of the federal government, we were able to amend our state plan, and we're very proud to say that Hawaii is the first state in the nation to offer this. We're excited to present further details on community palliative care benefit throughout this webinar series. And on behalf of Hawaii's Quest members, mahalo for your help in making community palliative care more accessible for all of our communities across our islands. Mahalo.
So thank you to Dr. Daniel Fishberg, who will be speaking today about palliative care. Dr. Fishberg has served as the medical director of the Pain and Palliative Care Department at the Queens Medical Center for more than 25 years, and is the chief of division of palliative medicine and a professor of geriatric medicine at the John A. Burns School of Medicine. Thank you, Dr. Fishberg.
Aloha. As a palliative care doctor, a day really doesn't go by that I don't have to explain to somebody what exactly is palliative care. I might need to be explaining it to a patient or a family that I'm meeting, learners here at the hospital, or even colleagues. So I've been asked to take a few minutes today to talk to you all about what is palliative care. So we're going to define palliative care and describe its role in relation to disease-modifying therapies. At the same time, I want to explain to you why the heck you should care about what palliative care is. So we're going to actually document some of the benefits of palliative care. So palliative care is a medical specialty. It's specialized medical treatment, and it's designed to prevent and reduce pain, symptoms, and stress for people living with a serious illness. Our goal is to improve quality of life for people with serious illness and their families. And that is one unique element of palliative care. Really, the scope of care is the family. Palliative care is appropriate at any stage of illness and in combination with curative and disease-directive treatments. So it's not palliative care instead of your usual care, it's palliative care in addition to your usual care. Palliative care by its nature is interdisciplinary. That means it's provided by teams with specialized training, doctors, nurses, social workers, counselors, and others. And these teams work together to provide an extra layer of support for the patient and their family. Now, those are all elements of palliative care as it's been defined by the Center to Advance Palliative Care and also adopted by our state in its definition of palliative care as it's developing this exciting new benefit to our state Medicaid program. So palliative care also, though, I've actually had some other definitions that have been handed to me over the years. So a very experienced nurse leader once told me that for her, palliative care really comes down to comfort, support, and choice. Comfort for the patient so they can have good control of their symptoms, their pain, their nausea, the emotional symptoms, support for them and their families so they can live each day the fullest and best, and choice, good information so they can make decisions to achieve their healthcare goals. A colleague of mine, Steve Pantelet at UCSF, says he uses this definition. He tells people that palliative care is helping you live as well as you can for as long as you can. And another colleague of ours, another national leader in palliative care, Ira Byock, he used this title for his last book, The Best Care Possible. And when you're living with a serious illness, we do consider incorporating palliative care into your treatment plan as very much the best care possible. So palliative care at its nature is preventive care. We are here to try to prevent health crises. And that's because you've got a team that's focused on symptoms and quality of life, and a care plan is in place to help manage those symptoms before a crisis develops. So that's why palliative care has to be available 24/7, 365 days a year, because believe it or not, symptoms don't just get worse Monday through Friday, 9 to 5. And more, we're finding that more medical societies are identifying that early referral is the standard of care. Oncology, cardiology, all of these medical societies are routinizing and putting into their treatment plans, and that palliative care is the standard of care and should be offered early. So palliative care really is additional care, and it's designed to complement, as I said, not instead of your regular care. And our message really, what we wanted people to understand is that people can have quality of life while they're getting treatment for serious illness. And very importantly, we want to recognize that palliative care should be offered based on the need, not on prognosis. Whether someone is being treated for cure or life prolongation, we want to make sure that if they do have a need, palliative care is identified and brought to bear. So I want to give you a real case example. This was a patient who was treated by our outpatient palliative care team, and everything in the case is unchanged except for the patient's name and age, just for to provide some anonymity. So Bobby was 58 years old, and he had recurrent lung cancer, so a cancer that had been treated and then had come back. That's usually a very serious situation and one where we may not be able to achieve a cure. On referral to outpatient palliative care, Bobby had terrible uncontrolled pain. His doctors had been doing their best and they had been really diligent in trying to manage his pain, but it really had been quite severe and hadn't responded adequately to the treatment by the oncologists or the surgeons. Bobby also had terrible respiratory symptoms. He had cough and shortness of breath, and he really just couldn't do the things he wanted to do. He wasn't able to work, wasn't able to do things with his family, wasn't able to garden, play golf. So all of this, of course, was really hurting his mood, and he had become quite depressed. So the first thing the palliative care team is they started looking at his pain a little more closely, and they noticed that he probably had a mixed picture of pain. It was both neuropathic pain and inflammatory pain. So some co-analgesics were brought to bear, and his pain got better. They then did a switch and added in methadone, which can be a uniquely helpful analgesic sometimes, especially in cancer pain management. And with his pain under much better control, Bobby's mood got better. By the third visit, They were having a conversation about what Bobby's goals of care were now that his pain was under good control. Bobby definitely wanted to fight for as much life as he could get. He was going to take whatever treatments were going to be offered to him. However, recognizing that the odds were somewhat against him with recurrent lung cancer, he did fill out a POLST form, a provider order for a life-sustaining treatment form. And while he wanted to treat reversible things, if he was going to die from this cancer, he didn't want to have his dying artificially prolonged on life support. So he elected do not attempt resuscitation with limited interventions, meaning return to hospital for reversible things, but avoiding life support. Well, Bobby started an immunotherapy trial. And to say that he had a robust response would be really the understatement of the century. He did fantastically, and his cancer responded so well. His respiratory symptoms very quickly improved. His cough and dyspnea got better. Bobby could basically go back to do all the things he had been doing. He actually came off of all of his pain medicines. We always often say that the best cancer pain medicine is effective cancer control, and Bobby definitely achieved that with his medical oncology team. He was doing so much better that really he was about as healthy as any of his doctors. So they actually revised his goals of care, and his pulse was revised, and it was now full support. Bobby actually no longer needed routine follow-up in the palliative care clinic, and 8 years later, Bobby remains cancer-free. But palliative care was an essential part of getting him through those treatments so he could have that tremendous response from his oncology doctors. Now, there's a lot of evidence to show, beyond the anecdotal evidence of Bobby, that palliative care reduces symptoms, improves quality of life. It's associated with much higher family satisfaction than standard care, and it improves transition management when patients are coming in from home to the clinic, to the hospital, or to a rehab setting. Having palliative care on board can make those much smoother transitions. And there's even some evidence that palliative care has been associated with a longer life. There are many more studies than what I've shown you here, but the font starts to get too small. So these are just some of the early ones that showed you that. But I do want to show you perhaps, the most seminal trial in palliative care. And this was one of the early randomized control trials of palliative care. And it was published in 2010 from the New England Journal of Medicine. Jennifer Temmel and her colleagues at Mass General and Harvard had 151 patients with new stage 4 lung cancer, so actually comparable to Bobby's situation, and they were randomized to standard of care at an excellent institution, obviously, or standard of care plus an early palliative care referral, not waiting till disease progressed or symptoms got worse, but palliative care right at the beginning, the way we recommend it now. And what they found was that across these three different quality of life measures, there were statistically significant improvements for the patients that got palliative care. Furthermore, if you looked at symptoms like mood, anxiety, and depression were much lower in the patients that got the early palliative care. And what was perhaps the most surprising finding in the study is looking at their survival curve. The patients that were randomized to get early palliative care lived almost 3 months longer. And this was actually back before the modern era of immunotherapy, molecular therapy. So that was about the survival benefit you might expect from chemotherapy back in that day. So it was really a robust response and very impressive. So there have been other studies that have shown survival benefits when patients are getting palliative care. We don't routinely say that palliative care is life prolonging, but I would really like to make the point that there has never, ever been a study that has shown a shorter survival with palliative care. So better quality of life and possibly longer life. So importantly, palliative care is available across different settings. Now, here in Hawaii, for many years now, we've actually had a lot of palliative care in our hospitals, and patients, when they come into the hospital, can get palliative care in many of the larger hospitals. But what's very exciting is that palliative care has developed in different community settings. So wherever patients are, they can now get palliative care elsewhere. And that's what's so exciting about this new benefit that we're having, our Medicaid benefit, the first federally funded community palliative care benefit in the nation. And I think it's because of all the great work that a whole host of people have been doing out here in Hawaii to show that palliative care in the community can be a very successful model of care. And so it's exciting now that so many more people will have access to this because of our new CMS approved Medicaid community palliative care benefit. So I'm going to summarize now. Palliative care is preventive care focused on relieving pain and suffering. We improve quality of life. We are interdisciplinary teams, and we work to provide that extra layer of support. Palliative care is person-centered and family inclusive. Remember, we combine palliative care with curative treatments, and it should be based on need, not prognosis. And finally, early referral has now become the standard of care across medicine. I want to thank you very much for your time and attention.
So our next speaker is Tori Fields. Tori is an MPH and the CEO of TFA Analytics. She was instrumental in the creation of the benefit and is now working on implementation. Tori serves as a strategic advisor to the Center to Advanced Palliative Care, or CAPC, the Coalition to Transform Advanced Care, CTAC, and the Hawaii Department of Human Services MedQuest Division. Thank you, Tori.
Thank you, Jeanette. I am here to give an overview about the community palliative care benefit that was approved as part of the most recent state plan amendment in 2024 for Quest. This will be the first part of a two-part series where we will talk about the nuts and bolts of what this community palliative care benefit includes. So, why are we delivering community palliative care to the Medicaid population in Hawaii? What we know is that people with serious illness need extra support from a multidisciplinary team that bridges all care settings, geographies, and cultures. People with serious illness need whole person care, and that approach includes not only the medical aspects of care, but the emotional, social, spiritual, cultural, and intellectual aspects, as well as support for family caregivers. And what we're all trying to achieve is that people with serious illness and their caregivers receive the right care at the right time in the right setting for them that's based on their experience and on their diagnosis. And this benefit really aims to close these gaps with a new reimbursement model and a new care model. So, where does community palliative care fit into the overall benefit structure for Quest members? There are a lot of benefits available for people with serious illness who are receiving Medicaid coverage. Some of the classic benefits that you see are things like home health and hospice. And there are additional benefits for older adults, home and community-based services, as well as for kids under the Concurrent Care for Children Services program. Palliative care fills a unique gap in the overall benefit structure for the Quest population. Unlike home health, palliative care does not expect for people to be homebound, and it's ongoing, it's longitudinal rather than episodic. Palliative care is different from hospice in that it goes much farther upstream. So it is not limited to people who have less than 6 months to live. We anticipate that people will receive palliative care for a much longer period of time. Palliative care can then be supplemented by things like home and community-based services, where palliative care is much more medical than those services delivered under the HCBS program. Those are just some key differences related to the benefits. So let's dive into the different elements of the benefit. First, I like to start with definitions. So palliative care has been categorized as a preventive service under the Hawaii State Plan Amendment. And what this means is that when filing the application for this palliative care program, the state selected the preventive services area of the Social Security Act to put palliative care in. So this definition that you're seeing on the screen is what was approved through this process. Palliative care is specialized medical care for people living with a serious illness. It is focused on providing relief from symptoms and stress of the illness. And its goal is to improve the quality of life for both the patient and the family. And community palliative care is provided or delivered in non-hospital community settings. We anticipate that these services are based on the needs of the patient and not on their prognosis, and that it would be appropriate at any age or any stage of a serious illness. It can also be provided alongside all of the other benefits available to the Quest population. A preventive service is the categorization of those services that actually prevent disease, disability, or progression of other health conditions. And preventive services have the aim of prolonging life and promoting physical and mental health and efficiency. And this is an exciting change for Hawaii in being able to look at palliative care this way, that palliative care prevents unnecessary pain and suffering from somebody's serious illness. That's how it was classified this way. So now that we know what palliative care is, let's talk about how we determine eligibility for the benefit. First, anyone accessing the benefit must qualify through an assessment to determine eligibility. That assessment will include two components to it. The first is meeting a qualifying condition, so the criteria for that, which will be a clinical diagnosis. The second is that people need to meet one element indicating functional decline. So before we explore the qualifying condition criteria and the functional decline elements, just want to give a couple of points. The first is a provider referral can serve as a positive screen for eligibility for authorization by the member's health plan. Health plans also can approve other conditions that are not considered qualifying conditions on a case-by-case basis. And Quest has worked to make this eligibility determination easier by specifying benchmarks and evidence-based tools to determine the level of functional decline that is needed. And we'll go through that in the next couple of slides. For some qualifying conditions, children will not need evidence of functional decline to qualify. While we know that in palliative care, we expect people to have concurrent services or access to all of the other benefits that are available to them, there are two exclusion criteria to note. The first is that people who are already enrolled in hospice cannot also access the palliative care benefit. And those enrolled in the organ and tissue transplant program, the SHOT program, cannot access palliative care concurrently. The qualifying conditions for adults and children fall under multiple condition categories. So when we're looking at eligibility, a person needs to meet the qualifying condition criteria and a certain level of functional decline. These categories are your regularly occurring serious illnesses, things like cancer, heart failure, COPD and other pulmonary diseases, renal disease and liver disease, neurologic, neuromuscular diseases, Alzheimer's and dementia, ALS, MS, Parkinson's, etc., and those conditions that are most commonly found in children, things like genetic disorders, neonatal complications, metabolic and gastrointestinal disease, or orthopedic disorders. For those condition categories that have an asterisk by them, gastrointestinal disease, orthopedic disorders, genetic disorders, metabolic disease, and neonatal complications, children do not need evidence of functional decline to qualify for services. Once somebody has been identified as having a qualifying condition category, then we need to determine evidence of functional decline. And a member must meet one of several thresholds that can be found on multiple assessment tools. So the next couple of slides will be about those tools that you can use and the eligibility thresholds to determine somebody's evidence of decline in function. Specialists and primary care providers have a lot of different tools at their disposal to really look at somebody and their evidence of need. Things like the Karnofsky Performance Scale, the ECOG status, Palliative Performance Scale, MELD, and FAST tools. All of those are evidence-based assessment tools to determine functional decline. And the eligibility thresholds on the right-hand side are the cut points by which we would anticipate somebody has ongoing decline in function or impact to their activities of daily living as part of their disease. In addition to those evidence-based assessment tools, we can use utilization and acute healthcare utilization, to determine somebody's level of functional decline. So, durable medical equipment or dependency, like 24-hour oxygen, use of a hospital bed, ventilator or wheelchair dependence, and dependence of other medical equipment can qualify somebody with serious illness as having functional decline. You can also use clinical biomarkers and evidence of comorbid conditions to determine someone's level of unmet need. And that unmet need can qualify someone for functional decline. The most common clinical biomarkers that are found in individuals with serious illness with decline are airflow obstruction, albumin levels, your international normalized ratio or INR, your filtration rate, and your ejection fraction, depending on the qualifying condition. Those with comorbid conditions and a serious illness may also qualify. So, people who are having chronic infections, progressive weight loss, pressure ulcers or ascites, and other issues like coronary artery disease, diabetes, dementia, etc., actually can demonstrate that somebody might be a good qualifier for the palliative care benefit. In addition to that, and especially for those assessing individuals in the hospital or facility setting, an individual with one or more hospitalizations within the past 12 months, one or more skilled nursing facility stays within the past 12 months, or multiple ER visits recently would qualify someone for the benefit. So they would have to have a serious illness and some evidence of healthcare utilization that demonstrates that they are using the healthcare system to manage their pain and symptoms. When we're talking about palliative care, we are talking about a set of services that are delivered by an interdisciplinary team. The services that an individual with a serious illness would need um, would be developed as part of an interdisciplinary care plan. that is in line with person-centered principles or that person's goals for their care. Providers should deliver care that reflects the culture of the person who is receiving it and their language preferences so that their needs are met. One thing to note about the covered services for palliative care is that people will have access to all of the other benefits available to them as part of their Quest coverage. So things like prescriptions and medical supplies, or home health services, or HCBS services will all be covered separately as part of their standard benefits. So in this case, what is palliative care? Palliative care has three components to it. One is the development and management of an interdisciplinary care plan. It starts with a comprehensive assessment using validated tools. And that comprehensive assessment and care plan will then yield an action plan for the interdisciplinary team. So the team delivering palliative care services will be providing those services under the benefit to address the holistic needs of the member and their family, focusing on relieving pain and symptoms associated with the serious illness, care coordination, and advanced care planning. These services are expected to be available 24 hours a day, 7 days a week, all year round, and really in line with what that person's needs are. So we anticipate that the types of services and the intensity of services might change over the course of somebody's disease while somebody is receiving palliative care. So who is on this interdisciplinary team? As part of the state plan amendment, Quest received approval for coverage for an interdisciplinary team. And what you see are two different components, the part of the team that is required and the part of the team that's optional. The team that is required to be available for any person enrolling in palliative care are a physician, a nurse, a licensed clinical social worker, a grief counselor, and a child life specialist, which is specifically for kids. We can also extend services through a larger team if somebody needs those types of services or that care. So that's the difference between optional or required. The optional team members will be extending the services for that required team. And that can include a nurse practitioner, a licensed practical nurse or an LVN, a certified nursing aide or a home health aide, community health workers, other mental health professionals, pharmacists, etc. These team members need to be available for both adults and children, with the exception of the child life specialist, which is specifically for children. Palliative care under this benefit is intended to cover services in all non-hospital settings. So unlike other palliative care programs, we anticipate community palliative care to not only be delivered in people's homes, but also in clinics or office settings, community health centers or FQHCs, assisted living facilities, long-term care facilities, skilled nursing facilities, and wherever somebody calls home. Quest does encourage that providers deliver at least some of those services wherever the member calls home, unless they prefer services be delivered elsewhere. So this covers outpatient and home-based, as well as some facility care. So how does all of this get paid for? This benefit is covered through a bundled payment structure, which means that all of the services we're talking about that the interdisciplinary team provides would be paid for under a single monthly payment that is paid to the provider for that full interdisciplinary team. Before that occurs, an assessment must be completed. So the assessment is actually billed outside of that bundle. Any billing clinician can be reimbursed for the assessment for palliative care services, whereas only qualifying palliative care providers can bill for the bundled payment or for the reassessment. So those are two separate qualifying criteria. What you see here are the HCPC codes associated with each one of these components. So the HCPC code for the assessment is S0280. For the bundled payment, it's S0311. And for the reassessment, it's S0281. And you'll see the descriptions for those codes underneath those numbers. Please note that providers who are billing on a UB04 will need to utilize the revenue codes also associated with palliative care services that can be found in the implementation memo. Here are some resources that you can review to access more information on the palliative care benefit. The first one is the implementation memo that was released at the end of December in 2024. And more information about the palliative care benefit can be found on the Kokua Mau website. So on the Kokua Mau website, what you can see are messaging resources related to what palliative care is and how a provider and a consumer can really better understand if palliative care is right for an individual, what its benefits are, where to find it in Hawaii, and information about palliative care for professionals and providers. Thank you very much. And we will deep dive into this in the second webinar.
Well, thank you very much to our speakers. And we have a really good turnout today, and there are some questions. So I'm going to start with the questions that we've gotten. So first of all, Tori, I think this one comes to you, and that is about assessment. There's actually a couple of questions about assessment. The first question was, are the assessment tools meant to be conducted by doctors only? And there were a couple other questions about assessment. So maybe you could talk a little bit about that, because that's also such a very innovative and game-changing piece.
It's a great question. The assessment can be performed when we're talking about the initial assessment or the reassessment. Those can be performed by any billing clinician. So it doesn't necessarily need to be a physician or an MD who conducts that initial assessment or the reassessment. When we're thinking clinically about assessments, there are multiple components to developing a care plan. And so it would be expected that as you're developing a care plan and you're performing, say, a social assessment or a spiritual assessment, that it would be conducted by the appropriate member of the required part of the care team, especially if somebody has you have identified spiritual needs or you have identified social needs, etc. So that's a way to really think about how you use the billing clinician, whether that's an NP or an MD or PA, etc., social worker, to conduct that initial part of the assessment, but then to really have that a comprehensive required team who can follow up on those things that you find initially.
Next question. Under cognitive, is someone with advanced dementia, Alzheimer's, etc., able to qualify?
Yes. Advanced dementia, Alzheimer's disease, et cetera. Those are all examples of cognitive impairment or cognitive decline that would be covered under the benefit.
There was also a question if the slides will be available. I can send out PDFs of that. So if people send it to info@kakuamau.org, I'm happy to do that. Okay, next question regarding a SNF. At a skilled level of care in a facility, the IDT is allowed to provide services, question mark.
At a skilled level of care, the interdisciplinary team can provide services. So you would need to be a contracted interdisciplinary team delivering palliative care, and facilities are settings where care can be delivered.
Great. Are all providers required to service pediatric patients?
They are not. That's a great question. So I would encourage you, if you're a provider and you're only serving a certain setting or a certain subset of the population, be that adults or older adults, et cetera, that you have that conversation with the health plan so that they have an understanding about the population that you serve. But it is not expected or anticipated that all palliative care providers will be pediatric palliative care providers.
How does HSBC bill for this under bundled, question mark?
Home and community-based services are considered a different or a separate benefit from the palliative care benefit. And so people who are who have home and community-based services needs can access home and community-based services at the same time as accessing the palliative care benefit. They're really sort of designed to go hand in hand, to be complementary, but not necessarily duplicative. And so if you are a home and community-based services provider, you would still need to qualify as a palliative care provider if you wanted to deliver both. So that's something to just note, that not all home and community-based services providers are palliative care providers. We anticipate there might be some overlap in terms of organizations who might deliver both. We anticipate that people with palliative care needs may also have HCBS needs. So that would still be an allowable part of the benefit if somebody qualifies for both.
Is the bundled payment prorated for less than 30 days of care?
The bundled payment is not prorated for less than 30 days of care. And the reason behind that is we anticipate that there are going to be different phases of somebody's care plan. And a lot of the time you see people who are starting with palliative care services get a lot of visits up front in order to develop the care plan and stabilize the patient. And so we wanted to be mindful of that, especially if somebody enrolls mid-month, that you might be expending that same amount of resources the first month as you would in other months.
Can the palliative care program provider bill fee for service simultaneously with the bundled payment? This is in regarding monthly fees, not the assessment.
That's a great question. So in the memo, what you will find is a series of appendices. There are two of them, one for Medicaid only and one for dual eligible patients. The codes that are included in the bundled payment are listed as part of those appendices. And if those codes are listed in the appendix, then you cannot bill separately for those codes. However, if you're, say, a social worker and you have an independent therapy practice, but you're also part of the interdisciplinary team, it's likely that some of the codes that you are billing for mental health services are not going to be in that appendix. And those would be circumstances where you would be able to bill for both services, one under the bundle and then one fee for service. So I would encourage you to look at those codes that are included in the bundle to make sure you're not doing some duplicative billing there.
Do all members of the interdisciplinary team need to be available 24/7?
Not all members of the interdisciplinary team need to be available 24/7. You do need to have some ability to respond 24/7 to pain and other symptoms or patient and family needs that arise. But especially if we're practicing things like anticipatory guidance, we would assume that a lot of these services can be triaged telephonically or by a nurse or by a physician on call, and that services can then be scheduled to support a patient during regular hours. Would you agree with that, Daniel?
Yeah, I mean, there would be certain things that require urgent response, and then certain things that there are other members of the team that would not.
Thank you. How about criteria about when it's appropriate for a patient to be discharged from palliative care?
Well, if somebody is accepting of hospice care and they are moving to hospice, that would be a time when they would be discharged. If somebody is in the SHOT program, then they would be in that program and would be discharged. If their goals of care are met and they no longer qualify for the program clinically, then you would discharge the patient then. And then if you have somebody who is lost to follow-up month over month, then that would be an appropriate discharge scenario. Oftentimes, what I have seen is that there's a underlying question here, which is about, say, if somebody goes into a facility or they get admitted to the hospital for a short period of time, and there's still an expectation that the palliative care team stays in place to help support care coordination and safe discharge planning and more longitudinal care. So this is something that we'll create a little bit more guidance about in the future, but the hope is that you're really able to coordinate care month over month for that patient. And if there are times when, say, a person, you're not seeing them for multiple months in a row, then you're likely to discharge them at the reassessment period.
Moving in the future, how will providers who need to make a referral know who's qualified and who are the credentialed palliative care providers? Is there going to be a list somewhere?
That is a good question. We are working together, Kokua Mau and MedQuest are working on developing some infrastructure in terms of having a website where some of these things can be more available. And if somebody has insurance coverage under Quest, then the health plan can also help to make sure that the palliative care team that you are referring to is in network with the health plan that person has. So, when in doubt, call the health plan to make sure that they help you understand which provider is contracted with them.
Good. I'm just going to keep going. My understanding is telehealth visits don't meet criteria for base clinician visits. Is that correct?
Telehealth visits do meet criteria as visits for the care team. There are certain parts of the memo that do outline when in-person visits need to occur. And so there is a minimum number of in-person visits that must occur, and the assessment and reassessment need to be in person.
Here's another question about assessment. Can a PCP do an assessment and code S0280 and then refer to the palliative care program? And then can that palliative care physician also bill for that same code? Okay.
Yes.
I see you nodding, so that's good. If someone is also eligible for supportive care through their insurance, which is the HMSA benefit, would they benefit from this, or are the two programs essentially the same when it comes to benefits and visits?
The supportive care program is one of those programs that, as outlined in the memo, will unwind June 30th for MedQuest patients and will be replaced by the palliative care benefit that we're talking about today. The supportive care benefit may potentially still be offered for non-Quest integration members, whether they be Medicare Advantage or commercial members covered by HMSA. So I would check with HMSA in terms of those other lines of business, but for Quest integration members, it'll be a transition from supportive care to this palliative care benefit.
So there's a couple of PEDS questions, but I would perhaps refer people to the session that we're going to do on the 23rd. On the 23rd of March, there's going to be, that is all about pediatric questions. So hopefully people can attend that. And just to remind people, next Thursday at this time, there'll be another session with also with more information, because there are, of course, a lot of questions here. Maybe one question that's come up a number of times is about the grief counselor. Can you talk, because someone said, I don't see a chaplain. What's a grief counselor?
That's a great question. The grief counselor terminology was what was approved by CMS. If you look at the memo and the requirements for a grief counselor, they include things like a degree in theology or training in spiritual care. So these would be technically synonymous with one another. So if you have a chaplain, that is the grief counselor component of the palliative care benefit.
What happens if a patient is hospice appropriate but does not want hospice? Can they remain in palliative care until they pass?
Absolutely. If somebody does not want hospice, then they are not eligible for hospice, because a critical component of the hospice benefit is patient choice. And if somebody does not choose hospice, then they are not eligible for hospice, and they would still qualify for the palliative care benefit. So it's absolutely understandable that not everybody will choose hospice, and that some people may die on the palliative care service.
Here's a number of questions have come up around care coordination, which I think will be a really important part of making this work. So, for instance, if a member has a health coordination and is on palliative care, the member would also have their own care plan under the health coordination RFP. If a member is also being followed by the palliative care team, will the member's care plan resemble the health coordination care plan, or is there a way to add the palliative care plan in as an attachment to the ongoing health coordination care plan?
Quest is working to align
Right.
the health action plan and to align the palliative care plan specific components into that larger framework. And so some documents that may be coming out in the near future are really some of those updated or supplemental pieces to that health coordination care plan. The memo does speak to the need for a lead care coordinator. And so we acknowledge that there may be other programs that somebody is accessing, or somebody might have a case manager from the health plan that's included in their care. And so what we really intentionally thought about was having a care coordinator from the health plan being a part of that person's care team, so that if there are multiple care plans in place, that we can identify a lead care coordinator, so that that lead care coordinator can pull together any of the other care plans that a person has.
Right. So that care coordination will really be important. In terms of initial referral, do we anticipate that it will be done by specialists or primary care providers or others? Certain specialists like oncology, cardiology, pulmonology may have a better expertise and interest relative to primary care.
What do you anticipate, Daniel?
You know, I'm biased because I tend to, here in the hospital, I work a lot more, with specialists than with primary care. But I would think that referrals would be coming from both sources. That, sure, the serious illness specialists in cardiology and oncology and stuff will probably be adopting this very quickly, but I would imagine that a devoted a primary care provider would be very attuned to the needs that might go unmet for their patients living with serious illness, and would also be sources for referral. So again, I've got my bias just because I don't interact with primary care folks a lot in the hospital, but I would anticipate referrals would come from both. Would that be your thought too, Tori?
I would hope so. Absolutely. And I think the more awareness there is about the availability of the benefit, the more opportunity there is to have primary care providers and geriatricians or community providers to actually really see this as a necessary component to their patients' care.
Yeah, and I think that that's this assessment piece is one of those. I think it could be a game changer that that more people will then be available to or be able to do that. So patient could still be in the hospital, correct, and be getting an assessment before their discharge. So it just opens up a lot more assessment possible. We are almost out of time. I think, Tori, you had mentioned before we can do like an FAQs with the questions that we haven't gotten to. Maybe perhaps one quicker question. Will it be required to have pre-authorization before the services are provided?
That is going to be up to the individual health plans as it relates to people accessing that bundled payment piece. So the assessment can be performed by any billing provider to assess somebody for palliative care needs, and then to make a referral to palliative care services. For the bundled payment piece, that's really subject to the health plans to determine what the authorization expectations are for that.
We did have one question about APRNs, which I know are important care providers. And, basically the question is, why are nurse practitioners not part of the required provider? Is that something you can speak to, Tori, or?
Yeah, it's a question we actually get a lot of the time, and we wanted to set minimum expectations around the interdisciplinary team so that there is also an ability to have other providers overseen by that required part of the team. So if you are a small practice or you're just starting out, you may only have a physician who is delivering the care and doing the oversight. As you start to grow, there's still a requirement to have a physician perform the oversight function of the role, but you may actually hire an APRN to start to deliver those services and to prescribe. And so from that perspective, an MD is still required to oversee the care team and to manage that plan of care. But you would anticipate that a lot of the work might be performed by nurse practitioners. And so that's sort of how that works. It's just acknowledging that for some programs it might be you might be too small or just starting out, and so you still have to get the doctor before you get the APRN.
She wrote again that they actually are an APRN-led team. So Tori and Daniel, what do you think what is your suggestion for moving forward? We have we can pull together the questions here and come up with FAQs like you talked about. We can also encourage people to write to MedQuest directly. Is that right, Tori?
That's
James
correct.
Chapman. I put James's email in the chat way at the beginning, so people could do that. And if you missed it, feel free to send me something at info@kakuamau.org. I can forward that along. I also would encourage people to attend the session next Thursday, and then the pediatric session, which is going to be on the 25th. So not on a Thursday, on a Tuesday. And then there'll be lots of questions answered about that. So again, I have found that the MedQuest office has been really very responsive to questions, and so I would encourage people to do that. We're going to finish up right now. Thank everybody for coming, and hope that people will attend the next session Thank you very much to Daniel and Tori for also coming live today and answering the questions. And thanks to all of you for participating and obviously being really engaged about this exciting new opportunity. So thank you very much for coming. Aloha.